at St. Louis University and a Doctor of Osteopathic Medicine at Kansas City University of Medicine and Biosciences. She is a family medicine physician at St. Luke's Bowman Woods Clinic in Cedar Rapids. In 2012, she completed training as a Creighton model and naprotechnology medical consultant. Dr. Minjeur has presented numerous papers and has held several leadership positions, including Chief Resident of Family Medicine and Student Ambassador at Kansas City University Medicine and Biosciences. She's a member of several professional organizations and has participated in medical missions with the United States and in Guatemala. Dr. Minjeur is also an accomplished pianist, not only in performance, but composition and instruction. She designs fabric and jewelry, and look out, she's a kickboxer. She does it all. Do you need this out of the way?
No, I'll come stand over there, that's fine,
Okay.
I just wanted that.
Do you need me out of the way?
I
could get lost.
Makes you happy.
Press the power button again.
Should we douse these lights?
Yes. Ta-da.
There you are.
Hang on a second, you guys aren't supposed to see all my notes though.
Oh.
Ta-da. All right, cool. Rapids, as she said, I'm going to give just basically a brief introduction on fertility awareness, natural family planning methods. As I was already introduced, a little bit about my background. I was born and raised in New Hampton, Iowa, which is a couple hours north and a little bit of west of here. I grew up on a farm. I'm the oldest of 5 kids, so I do not have any of my siblings' DNA within me. So I did my undergraduate study at St. Louis University and majored in theological studies with a minor in biology. Med school in Kansas City, and then trekked myself up to Mount Clemens, Michigan, which is a suburb of Detroit, where I met my husband, Carl, and encouraged him to come on back to Iowa with me after I was done. While I was in residency during my final year, I actually went to the Pope Paul Institute in Omaha, Nebraska, and received training specifically in Creighton model of natural family planning, as well as naprotechnology, and I'm a medical consultant through there. So, one of the big questions that always comes up is how does modern medicine generally correct menstrual irregularities and symptoms that occur around the time of a woman's period? Okay, if you come in and as a female to a physician's office, most of the time they say, oh, okay, we'll just put you on the pill or throw some hormones at you and we'll just fix it. The proposed way that they work, so if anybody has ever seen when you get your medicine, you get the side effects printed out on sheets or whatever. If anybody's actually ever read through, side effects and problems, as far as contraceptives are, it's like 75 pages and it's like teeny print. It's ridiculous. So as far as the proposed mechanisms of actions, this is at least what we learned in med school. We've learned that it's supposed to stop ovulation from occurring. Now, we know in reality this doesn't actually occur because some women still become pregnant, even if they're taking the pill. So obviously ovulation can still occur. We were told that hormonal contraceptives are supposed to change the cervical mucus to block sperm, when in fact there's really no scientific evidence that cervical mucus is altered at all. And in fact, Some women who are charting their cervical mucus around the time of ovulation notice, you know what, it still looks totally normal even if they're taking contraceptives. We're told that contraceptives are supposed to alter the movement of the egg, and that it can stop implantation of fertilized egg by changing the lining of the uterus. Now, with this final point here, notice fertilized egg. Okay, so fertilization still occurs, you know, ergo you're pregnant. It's just that the contraceptives are supposed to shed the lining of the uterus. And this is where I like to tell a little story about my education with pharmacology when it comes to medical school. So when we had a specific talk, it was an hour-long talk on hormonal contraceptives in med school, and the professor went through all of these proposed mechanisms of actions, da 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 da. And I asked in the middle of class, I was in a class of there's 250 students, so I said to him, I said, so you're telling me that the contraceptives are abortifacient? And he said, no, because of all of this stuff. And I said, but you said fertilized egg. He said, yeah, but the baby never develops. I said, but it's fertilized. He and I ended up having a conversation after class because, of course, I got cut short in our little 1 hour presentation. We talked for 3 hours before he could finally realize, oh, to you it means something different than what it means to me. And I asked him, I said, can you go back and tell the rest of the students and that? Because this is a big deal. These are 250 doctors just from my med school alone. He said, no, we have to move on to the next thing. And so, I think a lot of people get really, when we talk about this, when we talk about natural family planning, when we talk about naprotechnology, a lot of people say, well, my doctor's smart, they know all this stuff. You can only be as smart as what you know. If you don't know the whole story, if you're never told the whole story, you can't know. So I think, I get a lot of people that come in and say, well, my doctor never told me that, or da-da-da, and I think that's, important to realize is that not all doctors know everything. I don't know everything, and I think it's important to realize that, the people that are here, we can go back and bring that truth, to even your own physicians. So, switching over to the proposed mechanism of action of an IUD, an intrauterine device. One type, the Mirena, will release hormones to help reduce ovulation from ever occurring. But both types irritate the lining of the uterus to prevent implantation. Now, again, some women still get pregnant even with an IUD in place. And unfortunately, when that occurs, an IUD generally will increase the risk of an ectopic pregnancy, which basically means that either a tubal pregnancy or a pregnancy that occurs outside of the uterus because that uterus is so irritated from the IUD in the first place. Different reasons that contraceptives are prescribed for avoidance of pregnancy. This is an FDA-approved indication, and for acne, which is also an FDA-approved reason for prescription of contraceptives. The rest of these symptoms are not FDA-approved as far as reasons for contraceptives. This list is ridiculous long. I guess I look at this, and all of this is just Band-Aid approaches to all of these underlying problems. Something I always like to think about is if you were a male and you went into your doctor and you said, you know what, I have some really bad acne, your doctor wouldn't put you on the birth control pill. You know what I mean? I know that sounds funny, but truly, or I'm worried about my bones thinning. Okay, let's throw you on the birth control. We don't do that to guys. And so, I think it's worth saying, you know what, if there's issues that are going on, let's figure out what's going on rather than just saying, okay, here, take a pill. Disadvantages of contraceptives. I know on the little brochure that everybody registered for, it says 7 disadvantages of contraceptives. There's a lot more than that. Oh, thank you. All right, so the most common side effects we see of hormonal contraceptives: breakthrough bleeding, which means bleeding that doesn't occur at the time of a woman's menstrual cycle. Weight gain. Almost all women will gain weight, variable amounts, some just a little bit. And on the injection, like a Depo-Provera injection, most women averages about 15 pounds over the course of a year, sometimes more. So that's a pretty significant problem. Nausea and vomiting, and then decreased libido. As far as big time problems, side effects. Less common side effects: blood clots, DVTs, pulmonary embolisms, thromboembolism. I have 2 cousins who, for no other good reason on earth, had DVTs. Just being on contraceptives. They had the full genetic workup because they thought, oh, there's no way, Nothing else was found except that they had both been on birth control with no other good cause. Breast cancer, especially in women younger than 45. Cervical cancer in women over the age of 60. Liver tumors, gallbladder disease, hypertension, infertility, and ectopic pregnancy, especially with the IUD. Now, these are the major ones. This is part of that whole like 75-page thing that you'd print out if you looked at the side effects. So overall, general cost of contraceptives. I know this is a really busy slide. You don't have to memorize it. There's not going to be a test. But this is just to kind of give you an idea as far as the cost. Now, I will say I tried looking for better data. This is from 1996. So this is almost 20 years ago. So undoubtedly some of this, the cost has gone up. But you can see in general the cost, the one-time cost on the left here, and then lifetime cost over on the right. Now this is estimating that a woman's fertile years are about for 30 years from age 15 to 45. So that's where that lifetime cost comes up. All right, pregnancy rates and contraception. Another busy slide. Don't worry about the numbers as much, but I do want to make a distinction between typical use and perfect use. So typical use means the average Joe Schmo who wakes up in the morning and is like, okay, this is what's going on a daily basis. Whereas perfect use is if I did everything exactly like I should. So for example, look at the pill. So if you take your pill every day on time within 5 minutes of each other and you don't miss a single dose, perfect use pregnancy rate is supposed to be closer to 0.6 to 1.5%. When in reality, we all know, especially in younger women, they say, okay, you know what, I forgot the pill, okay, I didn't take it an hour apart, blah, blah, blah. So pregnancy rates are higher. So that's the difference between typical use and perfect use. Any questions so far on the contraceptive piece of stuff?
In the first talk in yours, nobody said anything about migraines. And I see that in virtually every woman that's come in that's had,
Yes.
that's on the pill. They
Yes.
have headaches.
Yes. Yes. It's a big problem. And that's why I said those are the most common, but yes, definitely migraines, headaches, just general malaise and feeling yuck. I think part of that is the struggle between your body's natural hormones trying to do their thing, and now all of a sudden you're throwing different hormones in at different times of the cycle. So yes, migraine's good. Any other questions? All right, good. Now I'm going to switch topics a little bit to my actual favorite part of this. So advantages of different fertility awareness methods or natural family planning. They are adaptable to any cycle length or circumstance. They are medically safe, so there's no hormones, no chemicals, no devices. Proven to be reliable. I'll show us a big slide on that a little bit later on. Comparatively inexpensive, so depending on which method you're learning, lifetime cost averages anywhere from $0, depending on who teaches you, up to roughly about $800 for a lifetime cost for teaching and supply. So if you think back to that other slide with some of the other costs, it's like, okay, that's much more doable. It is standardized, and you can avoid all of those nasty side effects from synthetic hormones. And the other beautiful piece of it is that it can create a joint responsibility between spouses. So rather than, okay, did you take your pill today, or did you do this, or whatever, now it becomes a joint responsibility, so both partners know what's going on. Disadvantages of fertility awareness methods, just to be fair, there is a bit of a learning curve. So it's not just, okay, I'm going to slap the little patch on and I'm good to go. You do have to learn it. You can't just kind of practice this. Okay, so it does take some dedication and commitment. You can't just say, okay, today we're using NFP and tomorrow we're not. It's a focused thing. So how many methods of fertility awareness are out there? This in general is 7-ish. There may be more. Okay, these are ones that are more well known. Now, I'm not here to sell you on any one particular method because they're really, some of these methods work great for some women. Some of them work terribly for some women. I will say my training is in the Creighton model system, and the big reason for that is because it has the additional piece of it that's called macro technology, which allows me to kind of handle some of the medical concerns that come up along with it. But we're going to just kind of go briefly into some of these other methods just so you can kind of know what's going on. All right, so basic concepts. This is biology 101. Men are always fertile. Okay, pretty much starting from like age 12 to 13 all the way up. Sperm are there 24/7. Women are not always fertile. As Vicki mentioned, there's really only a period of about 24 hours, so it depends upon the time of ovulation. So fertilization requires 3 things: egg, sperm, and then cervical fluid or mucus. Okay. The big reason that this comes in is that you'll see it is a part of many of the different types of natural family planning or fertility awareness. So just an overview of the different methods. We'll start with the calendar or rhythm method. And so for a lot of people, this is when you say natural family planning, this is what they think of. They think, okay, you're counting days. So it strictly calculates the days of fertility based off the number of days in previous cycles. It's more effective if you always have the same number of days in every cycle, but it does have a little bit of a lack of versatility. So for people who are breastfeeding or have irregular cycles or prolonged anovulation, it's kind of tough. It does lack a bit of precision because of that. Now, if you're somebody who your cycles are always 30 days apart and you know that you always ovulate on day 15, this might work for you, okay? But for a lot of women, it doesn't. This was a fun little picture that I found. This is probably something that my grandma would have had. And it's just an old dial, and literally it says down here, so this is the fertile days, number of days in your period, and then this says the next menstruation begins. And so what they would do is that when they started their period, they would turn their little dial to make it so that they knew, okay, hey, I knew that I have 30 days in my last cycle, so I'm on day 7, whatever the case may be. And so it literally is just as strict as just a graph, okay? Next method is basal body temperature. And this relies on taking daily temperatures. Now this method is just the temperature method. To help determine the time of ovulation, it must be taken at approximately the same time daily. And it is affected by lack of sleep, alcohol, illness, sleep deprivation, stress, shift work, if you take it a different time of day. And so this can be really, really tough for people who have a lot of stuff going on. So if you think about even somebody who has a toddler, okay, you're up at all sorts of different times of night, they get sick. So it can really kind of fluctuate with that. About 5% of cycles have been shown to have ovulation earlier than expected, just based on this. And then the other kind of concerning issue is that if there are some irregularities in hormone levels, you don't necessarily have that temperature spike. So some women may be ovulating, but they don't have the hormone spike, and so it just looks like a flat line. So that can be kind of tough with this. Next one here is symptothermal method, or couple-to-couple-y. It integrates a bunch of different symptoms, including cervical mucus observations, breast tenderness, vulvar swelling, ovulation bleeding, changes of the cervix, and also includes the daily basal body temperature as part of the methods for tracking. Some concerns with that, there is some variability in symptomatology, and so what for one woman may be, what they consider to be clear mucus may not be clear for another woman. Then again, with the daily temperature readings, the same as I had mentioned before with the changes in that. Marquette method, this is one of the newer methods out on the block. It utilizes mucus observations plus a daily urinary ovulation kit. So you literally purchase this fertility monitor and the test strips that go with it. You pee on it every day, you stick it into the little meter, and it tells you if you're ovulating or not. Some people prefer to have this because it's a definite answer of knowing that a hormonal shift has occurred. They're literally able to see, yes, I've ovulated, or no, I haven't. The tough thing again with this is that sometimes that may be different depending on the hormone levels. And then the final two are kind of lumped together here, Billings and Creighton models. They are two distinctly methods. Dr. Hilgers, who developed the Creighton model, did learn with and got a lot of his education from Dr. Billings, and so that's why they kind of go together. So both of these methods are what we call mucus-only methods. So they rely strictly on observation of the cervical mucus in order to determine where you are in the cycle and if there are any concerns or problems. It is able to be objectively identified, and so you're able to say, okay, today my mucus stretches this much, it is this color, therefore this is where I am in my cycle, and I'll show you a little bit later of the charts of that. It allows for medical identification of irregularities, and so this is part of it that really got me interested in learning Creighton model is this NAPRO technology piece, which again I'll talk a little bit more on that later. And the other beautiful thing, it's able to adapt for any and all cycles: breastfeeding, perimenopausal, infertility, anovulatory cycles, or variable length cycles. And so this is one of the only methods that is able to account for all of those things and still maintain the same precision and accuracy throughout. So this is going to be a slide here on natural family planning methods, the pregnancy rates, because a lot of people always say, you know what, you're using NFP, yeah, you're going to be pregnant within a year. I know when I first moved to Cedar Rapids about 2 years ago, the first physician that I went to saw, I told her that my husband and I practiced natural family planning when she asked me what I was on for birth control. And she said, well, I hope you're taking a prenatal vitamin because you'll be pregnant. And I said, well, we've been married 3 years and, we're using the method effectively. And so I think that's a big misconception is that the pregnancy rates are higher just because you're not doing something hormonally. The other thing is that with this slide, all of these studies are based on the people, on whoever created the system. So, for example, Dr. Hilger's it's his pregnancy rates from their study. So what this is on the left here, it shows which method it is. And again, actual use versus perfect use, like we talked about on the other slide. So actual use is the day-to-day. And then perfect use would be, theoretical, more so. I think the other thing that comes up is that when you read studies that talk about failure rates of NFP, what they consider a failure rate is pregnancy. Okay, so if you consider pregnancy to be a failure, then sure, that'll count. So a lot of times when they look at those studies, they say endpoint is pregnancy, therefore it's failure. Rather than saying, oh, was the couple trying to achieve pregnancy? Because, that's one of the beautiful things about any of the fertility awareness methods. You can use it to try and avoid pregnancy, to try and achieve pregnancy. And a lot of times the studies don't delineate that. And so, I think that's important to know. Did the study take into account whether or not the couple was trying to achieve pregnancy? I'm going to shift gears now and kind of just focus more on the Creighton model side of it because, like I said, that's more where my training is, and it kind of touches into the naprotechnology side of things. It can be used to achieve or avoid pregnancy, as we said, as with any of the other methods as well. It can be used to evaluate infertility, evaluate irregular cycles, and unusual bleeding. It can help to identify ovarian cysts without even needing to get an ultrasound. To treat PMS and to treat postpartum depression. So there are specific, well thought out, defined protocols for treatment of all of these things. What cycles will it work with? Regular cycles, irregular cycles, and ovulatory states. So in women before they're having regular periods, maybe just when they've started having periods, or in women who are approaching the menopausal state where they're starting to have some ovarian failure. Breastfeeding, premenopausal state, and then post-pill or patch or injection. So a lot of times in women who are trying to get pregnant, they're coming off of some of these hormones and it can just really rock their cycles and make things really crazy. So charting with Creighton model, I'm just going to give a brief overview of the method. Now, this is important. This information here is not enough for you to go home and say, oh yeah, I'm a Creighton model expert, I'm going to just start doing this right away, okay? There are at least a couple of local certified instructors here that you can get more information from if this is something that you decide you want to learn more about. So this is just very, very brief. The general training that we do to get all of this, it's 1 week in Omaha, and then it's 6 months of self-study, and then another full week in Omaha just to learn the method well enough. So for individuals that are learning the method, it doesn't take quite as long, but it's a lot of stuff here. So this is the only method that has the ability to be utilized with that naprotechnology like I talked about. So the picture dictionary is one of the methods that we use in order to actually help teach women what's going on with their cycles. Now, this is not showing up well at all, I'm very sorry. But basically what it is that there are specific pictures, specific descriptions of what's going on, so that if I look at a chart from one woman and her chart says 10 KL, and I look at a chart from another woman and it says 10 KL, I can know that it means the exact same thing in my head, because we teach the method so that you know the pictures, you know what's going on, and then what there is this additional nomenclature, numbers, letters. See, this is why you can't learn it just in a little 10-minute session here. But basically, so then I know, from each woman, cycle to cycle, that I can see what's going on. So this is basically what a normal cycle will look like when we do charting. So we try and make it very, very simple. So red obviously is for bleeding. And then most women will have a period of dryness, or maybe not, which means green. So when we explain this to spouses and husbands, it's like, if you're trying to avoid pregnancy, green means go. Okay, so if that's a time that you're trying to be able to have intercourse and not get pregnant, green is go. Then the next set of stamps here, they're actually little babies on the stamps, okay? So that if you have intercourse during this time, you could get pregnant. That's why there's little babies. And then the green again for go, okay? The reason they made this method simple is, first of all, they wanted it to be able to be standardized across the board. The other really cool thing is that this method has been taught to women literally all over the world. Women who are not able to read or write, women who are not able to, necessarily communicate and understand, oh, okay, what does lubricative mucus mean in my cycle of ovulation of LH, FSH, da-da-da. They aren't going to know all of that's going on, but they make it simple enough so that everybody can know what's happening. This shows, so this is just each month. So that's 1 month of her cycle, this is the next month. These three cycles are all in the same woman. Okay, so you can see it varies a whole lot from cycle to cycle as far as how many days it is, 28 days, 25 days, I think that's 33 days from cycle to cycle. And if you look at where do the little babies fall, it's very different from each cycle. And so for somebody that's trying to get pregnant, if they've been told, you know what, aim for day 14, and that's probably when you're ovulating, in the first cycle, yeah, that works fine. Okay, that little P means the peak day or the day that she's ovulated. But on this cycle, it's on day 9. On the next cycle, it's not until day 21. And so this is normal, okay? I would not do anything different with this chart. There's nothing else that needs to be managed about it. But it just shows that from each cycle, it can be really variable from each woman. So any questions on this piece of it? Okay, good. And then the last little section that I'm supposed to chat about here is infertility and the prevalence of infertility. People are saying, okay, are more women infertile now than there was before, or what's the case? I think the numbers can kind of show here. Number of women with impaired fertility, this is an average, and this is information from the CDC. And then prevalence among married women, so anywhere between 10 to 15%, depending on what year it is. They generally will describe infertility as being trying to achieve pregnancy for the course of 1 year and not being able to become pregnant during that time. So when is the best time to get pregnant? So any time that there is cervical mucus present, you can be fertile, although not all mucus is considered the best time to try. If people are having problems with getting pregnant, we tell them to aim for that specific time of ovulation or aim for that peak day, and trying for intercourse every other day around the time of ovulation. You can still be fertile up to 3.5 days after the day of ovulation if there's been an active intercourse during that time. So as Vicki mentioned, 24 hours that egg is alive, but sperm can survive for up to 3 days. Sometimes 4 is kind of pushing it sometimes, but generally up to 3 days during that time. So on average, how many days each cycle is a woman fertile? So it's different for every woman. Average is around 5 to 12 days per cycle. And then again, like I said before, all days that mucus are present are considered to be fertile days. This is just a little graph of people with normal fertility and that were trying to achieve pregnancy. So along the left side here, it's cumulative pregnancy rate, and along the bottom, the cycle the pregnancy was achieved, so each consecutive month. So this is granted a small study. This was only a study of 50 people, but of those 50 people, when they knew, it was on normal cycles. Okay, so it's a very different looking graph for people that have some impaired fertility issues. Again, this is just a graph of trying to achieve pregnancy during a regular cycle. And so everything looked normal. Peak day is the day of ovulation. These little I's stand for intercourse. Okay, so that's the time that was occurring. And then they got, I think it's really funny, they got all the way down here, and they were 11 days afterwards. So this person had waited 44 days since their last period before they took a pregnancy test. Most people take it sooner than that, and they take about 5 of them at a time. But anyways, that's when they had the first positive pregnancy test. Most women, you can test on about 15 to 16 days after your last day of ovulation, and you'll have a positive pregnancy test if you're pregnant, even with just a dollar store pregnancy test. Okay, a lot of people come to the doctor because they say, "Oh, you guys have something better." No, it's pretty much the same thing. Okay, sometimes they're a little bit more accurate, but we still say roughly 15 to 18 days after you've ovulated that we'll be able to figure that out. This is achieving pregnancy in a long cycle. So remember, like I had said before, a lot of people will say, "Oh, I'm trying to get pregnant," and they say, "Okay, aim for 2 weeks after your last period." Now, if this couple had aimed for day 14, they probably wouldn't have gotten pregnant because she didn't ovulate for another whole 10 days. Okay, but because they knew that that's when she ovulated, they were able to focus their intercourse and be able to achieve pregnancy. This is probably one of my favorite slides. I know it looks crazy for you guys. I just like colors and lines and stuff. But so this is actually 3 different women on the same chart. And basically it's showing the fertility focused intercourse. Now the reason that this is so cool is because all 3 of these women were told they would never get pregnant because their husband's sperm counts were too low. Okay, normal sperm count when it's evaluated is somewhere around 20, 25 million. Okay, they say anything less than 15 million is considered no good. Very top line, this man in his sperm analysis, they found only 30,000 sperm, okay, as opposed to 25 or 30 million. They were able to get pregnant because they focused right around the time of intercourse. It only takes 1 sperm, okay? You don't have to have 25 million. Okay, second line here, this was a couple that had 116,000 sperm. And again, based on fertility-focused intercourse, were able to become pregnant. The other thing with this chart, look at how long it took until she finally ovulated. She was on day 31 of her cycle. Okay, so a couple things going on here. And again, she waited, until back there before she had a pregnancy test. And then this bottom line here, this couple had sperm count of only 50,000. In somebody that looks like she has a normal looking cycle. And so again, they really focused intercourse towards the time of ovulation and then were able to obtain a positive pregnancy test and a beautiful baby. So the NAPRO technology, so this is, like I said before, this is kind of the bread and butter of what I do. NAPRO technology stands for Natural Procreative Technology. It utilizes what's seen in the Creighton model charting to formulate an approach to evaluate these menstrual cycle irregularities that so many women have. I use it a lot in helping to evaluate couples with infertility, polycystic ovarian syndrome, which is seeming to become more and more of an issue. Premenstrual syndrome, or PMS. A lot of people just think, oh, she's moody and whatever and going crazy and she just is PMS-y. Well, PMS is a disease. It's not a normal state. And for a lot of women, we've been able to get a lot of good relief, good help through evaluation of their symptoms. Evaluation of long and irregular cycles, and then irregular bleeding. So what does evaluation consist of? It's typically at least 2 cycles of charting, which you can learn through the fertility care practitioners. And then targeted lab work evaluation around the time of ovulation. And so in general, a lot of OB offices, if they're doing a workup for infertility, they'll say, okay, you ovulate on day 14, so therefore we're going to draw your blood on day 15, and then we'll know whether or not things are good. Well, as I pointed out earlier, it's not a cookie cutter thing for people. So we have to know when are you ovulating, and therefore time your lab work for after that's done. And then an ultrasound to assess anatomy. So as Vicki was mentioning before, some of these women may have uterine anomalies. We have no idea that's going on until we do the ultrasound. NAPRO technology treatments. And I hesitate to go a whole lot into this because there's the book that we learned, it's ridiculous. It's probably like a 5-inch thick book that talks about diagnosis, treatment, all that stuff. So just in general, the treatments are dependent upon the diagnosis. A lot of times it will include bioidentical hormone supplementation, which we time to the cycles. May include some vitamin recommendations, and sometimes requires specialized surgical intervention. So just as a brief example, for somebody with PMS symptoms that comes to me for evaluation of their concerns, they'll be charting, they'll bring their chart to see me, we'll do a lab work evaluation timed around the time of their ovulation, and then depending on what their hormone levels show, determines what we would prescribe for treatment. So for some of these women, it ends up being that they have a progesterone deficiency. For some, they have a progesterone and an estrogen deficiency. Either of those things we can supplement. For some of them, their hormone levels look totally fine, but their endorphin levels may just be low. And so we supplement with a medication called naltrexone, which can help to boost the endorphin levels. And so it kind of depends as far as what's going on with the hormone levels that can really help this. And I think in the past, a non-NAPRO doctor or somebody who hasn't been trained in all of this, they might just say, just go on the pill, it'll regulate the hormones and be good to go. When in reality we find that a lot of these women don't have a hormone imbalance. It may just be, like I said, this endorphin imbalance or some other problems that way. So that's just in general, kind of a brief overview on that one. So that is actually all that I have, and I would be more than happy to take any questions if anybody has anything. Yes?
Can you explain bioidentical hormones?
Yep, absolutely. So So there are different types of chemical structure that's made up of hormones. So when we talk about bioidentical hormones, they are hormones that are identical to the hormones that are created in our own bodies. So it is not necessarily, it's not like we're extracting the hormones from one person and giving them to another person, but they are still engineered to be the exact same makeup, as opposed to what they call isomolecular hormones. So for example, progesterone is a great example. So progesterone, there are lots and lots of commercially available brands of progesterone. Many of them are synthesized from, they take pregnant horses and they take their urine and then they break that down because there's progesterone in it, and then they use that progesterone and put it back into the medications that we get prescribed, the progesterone. And so that's the big difference is that rather than being from a horse, it's progesterone that is similarly identical to what we get as humans. And so that's the hormone that we get. So most of the times that will come in the form, it can still be made into a capsule, vaginal suppositories, injectable. I mean, there's all sorts of different types, but there is a very distinct difference. And there's been a lot of research into showing the bioidentical is the way to go, because why would you want to ingest something that's pregnant horse's urine breakdown? I don't know, especially if you have an option, So, did I answer your question? Other questions? Yes.
Probably too complex, but there's somebody in our extended family right now who's dealing with the eggs being too old, aged by having been on contraceptives for years. In terms of the charting, is there a way that would be noticeable as a diagnosis?
Yes. So, especially we see this, when women are getting closer to the age of menopause. A lot of times the cycles will stretch out in length, and a lot of times the time period between when they ovulate and when they have a period will shorten. We see that a lot with progesterone deficiency. Okay, a lot of it is because you need to, in order to ovulate, you need to be able to have those peaks of hormones, and if that's not happening, then ovulation keeps getting pushed back and delayed. So yeah, generally we see it not only as a longer cycle initially before ovulation, but then oftentimes a shorter, what we call post-peak phase, when the progesterone levels don't have that spike. Interestingly enough, there's also great variability between cycles. They're doing a lot of research right now into looking backwards at women who have developed breast cancer, and women that have been charting, especially using Creighton model, and that know exactly when they've had their peak day, and they're kind of backtracking and saying, oh, you know what? Even before the breast cancer was detected, the hormonal imbalances started going really crazy. And women may not have noticed it because my periods were still coming every 30 days, but when I ovulated it was very different from month to month. And so that's a really cool, exciting new area of research that's going on over at Football in Omaha. Other questions? Yes?
What number of young girls who are normally on the pill will come to you to get that treatment? And got married? Is that a struggle with parents? And how do you talk to parents about that?
It can be a challenge. I will say that probably I'm blessed in that the majority of the people that come to me, oftentimes they don't want to be on the pill, but their daughter has such terrible, painful periods that they're missing school. And whoever their last doctor they saw was, they just said, okay, this is all I got, so here you go. I would say the majority of them that come to see me want to be off of it and are willing to work to find other ways to do it. But there definitely are always some that are just like, nope, you know what? I'm not even having sex, so it's not a moral, ethical concern. But as Vicki pointed out, it is. It's so much more than that. So I would say for the most part, like I said, people that come to me want to be off of it. So the big majority of the two biggest populations that I see would be infertility patients and, exactly as you described, young women who aren't needing contraceptives for birth control necessarily, but just want to be off of it because they were put on it because of acne or migraines or PMS symptoms. So, does that answer your question? Anything else? Okay, I apologize in advance. I'm the one with the 4-month-old in the back, so if she screams and cries, I'm very sorry. She's just kind of been sick today, so we're rolling with it. So my apologies in advance to everybody. So thank you so much for being in tonight.